So Beth is from the University of Ottawa. She has a PhD in epidemiology. She's been working on designing outcome sets for PKU disorders as well as other rare diseases. Beth and the ACD have a bit of a history. She's worked with us in the development of our PCORI grant, and she's also helped us with some patient registry related survey design and the like. And today she's going to be talking to us about her work with another rare disease. Her abstract is titled, or her talk is titled, Core Outcome Sets, Engaging Patient and Families in Consensus Methods to Identify Outcomes That Matter Most. I trust that this talk, much like others in this session, will be very relevant to the patient families. So looking forward to participation at the end of the session. Beth, take it away.
Great. Thank you so much, Sangeeta. So as you mentioned, I will be talking about the development of core outcome sets in the context of some other rare inherited metabolic disorders, but with the hope that the methods that I'm going to talk about, I think, would be potentially transferable to CCDS as well. Just a second, sorry. Okay. So as you all know, in rare diseases, we typically have quite limited evidence to guide healthcare decision-making for a number of reasons, including small, geographically dispersed patient populations, and also a lot of clinical heterogeneity, even within the same rare condition. And so we need to make best use of our limited research resources, ideally with studies that include robust designs, for example, clinical trials, when we're looking at intervention studies, and studies that address questions that matter to patients. So an important piece of this is outcomes, as we've already heard. And so we need to study outcomes in order to identify whether interventions are effective and whether they're safe. And that includes, for example, results of lab tests, information about how patients feel or function, and observable symptoms. So the outcomes that studies measure can determine what evidence is considered in clinical decision-making and health policy decision-making, which really underscores the importance of selecting outcomes that are relevant to all key stakeholders, including patients and their family members, healthcare providers, and policy decision makers, so all rare disease decision makers. And having more harmonized outcomes across studies helps to facilitate comparisons across studies and also allows us to pool together and synthesize research so that we can make decisions based on the best available information. So core outcome sets, or a COS, is an agreed set of outcomes that's recommended for inclusion in all pragmatic, so effectiveness clinical trials and observational studies as well in a specific disease area. So core outcome sets can help to facilitate high quality standardized collection of outcomes that are meaningful to the decision makers, so patients and family members, clinicians, policy decision makers, and as I mentioned, help to ensure that results can be compared across studies. So the Core Outcome Measures in Effectiveness Trials, or COMET initiative, is a worldwide initiative that's led out of the UK that was launched quite a few years ago now to bring together and provide resources for researchers who are interested in developing core outcome sets. It's not specific to rare diseases, so there are hundreds of core outcome sets that are part of the COMET initiative in all kinds of disease areas. And there's a handbook produced by COMET that outlines the recommended process for developing an evidence-based COS. So as I mentioned, I'm a researcher, I'm an epidemiologist and health services researcher, and the research network that I'm part of, the Canadian Inherited Metabolic Diseases Research Network, has the goal to generate evidence to improve healthcare and outcomes for children with inherited metabolic diseases and their families. And so our network decided to develop two core outcome sets, one for each of two of the most common inherited metabolic diseases in children. So medium chain acyl-CoA dehydrogenase, or MCAD deficiency, and phenylketonuria, or PKU. So really briefly, for people who aren't familiar with these conditions, children with MCAD deficiency have an inability to break down medium chain fatty acids, which is a metabolic pathway that's particularly important during times of catabolic stress. So for example, fasting or during times of acute illness. And these children are at risk for developing acute metabolic crises that can be life-threatening during these times of stress. And so in addition to avoidance of fasting, they require medical monitoring and emergency management frequently during these high-risk periods. Children with PKU have an inability to break down the amino acid phenylalanine, or Phe, which leads to an accumulation of Phe in blood and tissues and carries a risk of behavioral and intellectual disabilities that can be mitigated with the early initiation of an arduous Phe-restricted diet and frequent monitoring of blood Phe with adjustment to the diet. So I'm not going to say anything else about those two conditions, but just a really brief background, and I'm going to focus on how we developed core outcome sets. So we followed the process that's been recommended by the COMET initiative, and our project was part of that initiative. This included conducting a systematic review of the literature. So we looked at past studies of PKU and of MCAD deficiency in children to develop a list of the outcomes that had been measured in those past studies. We then used a series of multi-stakeholder Delphi consensus surveys, and I'll talk a little bit more about what those were in a couple of minutes, to narrow down the list of outcomes for each condition to 20 outcomes that were then taken forward into a consensus workshop to decide on our final list. And the recommendation from COMET is to have a list of 6 to 9 outcomes that are part of the core outcome set. And so it's important to involve patients and their families throughout the process. And so I'm just going to talk for a moment about our patient engagement strategy. And so here, of course, we had patients and families as participants in our surveys, but here with patient engagement, I'm talking about having patients and family members as part of the research team, so as partner co-investigators and advisors. So there were 2 rare disease patients or caregivers with experience in research who were co-investigators as part of our study team and involved in the development of our protocol from the beginning. And they helped us to identify barriers to incorporating broader patient and caregiver perspectives in developing a core outcome set, co-designed solutions to address these challenges, and co-led all of our patient engagement activities for the study. We also established a family advisory forum, which included 7 parents of children with inherited metabolic diseases recruited from 2 pediatric treatment centers. And these advisors received comprehensive training that was developed and delivered together with the patient partner co-investigators on research in general, core outcome sets, and the specifics of this project, which helped to support them to be able to provide feedback and advice to our research team at key points in the project, including, for example, all of the patient participant facing materials for the surveys. And they also participated in our final consensus workshop as voting members of the workshop. So I won't talk in much detail about the specifics of the systematic review findings. I know the interest of this group is really not specifically in MCAD deficiency and PKU, except to say that, for example, there was a much larger literature for PKU, so over 300 articles that we identified and extracted information from compared to MCAD deficiency. And what was really notable in the literature, and I suspect this would be common across many rare metabolic conditions, is that compared to the number of articles, there were many unique outcomes measured in these past studies. So there's not very much consistency at all in terms of what we're measuring in studies of these 2 conditions. And as well, particularly I would say for PKU, there was a dearth of studies that measured what I would consider to be more patient-centered outcomes. So there was a heavy emphasis on blood Phe concentrations, which is a really important outcome for PKU, but a kind of a lack of focus on things like quality of life, for example. So briefly, a Delphi consensus survey for people not familiar with this method is essentially a multi-round survey, the goal with the same participants, and it's essentially a variation of the same survey. And the goal with each subsequent round is to present people with their own answers from the previous round, as well as the aggregate answers from the group, and allow them the opportunity, if they want, to change their response. So we conducted a 3-round web-based Delphi survey separately for MCAD deficiency and PKU that included 2 groups of experts, people with lived experience. So these were parents or guardians of children with MCAD deficiency or PKU, and then healthcare providers and policy decision makers. So in the first round, we presented participants with each of the outcomes, the candidate outcomes from our systematic review. And for each outcome, we developed an accessible definition, and we asked people to rate how important they felt that outcome is in studies to evaluate interventions for the condition on a 9-point scale. This is all part of the COMET initiative established methods. And then in the second 2 rounds, people revisited their ratings, and they were given the aggregate results separately for the 2 groups of experts. So they were told, this is what families said about this outcome. Here's what healthcare providers and policymakers said about this outcome. Here's what you said in the previous round, and they could revise their response. And then we considered consensus to have been reached on an outcome if at least 70% of respondents in either group said that the outcome was critical, and fewer than 15% said it wasn't important. And so we used this Delphi process to narrow the list of outcomes down to 20 per condition to take forward into our workshop. So this is just a really quick summary of the top 5 rated outcomes for each condition from each expert group at the end of 3 rounds of the Delphi survey. And I'm just showing this basically to show you the outcomes that are shown in red on the slide here are those outcomes that were only rated in the top 5 by the parents or guardians, or only by the clinicians and policymakers. So there were some important differences here, underscoring the importance of including multiple stakeholders. Our consensus workshop was held in person because it was pre-COVID, and we had 18 participants, including patients and their family members. So these were the advisors who'd been part of the team, clinicians, and then other investigators, so methodologists like myself, or some people with health system expertise. And we used a 3-step approach at the workshop. So we reviewed all of the findings from the literature review and from the consensus surveys as a group. And then we used what's called a nominal group technique, an adapted version of that, where each person was given, I think it was 1 or 2 minutes to address the entire group, including patients and family members, to tell us what they thought were the 3 most important outcomes and why. And then we used anonymous real-time voting. And everyone was asked to vote on each of the outcomes according to, giving a score of 1 must be in the core outcome set, 2 strong contender, or 3 can be left out.
Beth, you have the last 2 minutes.
Okay, thanks, Sangeeta. I'm almost done. So at the end of the day, we developed our 2 core outcome sets based on this process. For MCAD deficiency, 8 outcomes and 9 outcomes for PKU. Another goal of core outcome set development is to have a distribution of outcomes across these a priori defined core areas. So things like growth and development, life impact, and it is recommended to include at least 1 outcome that's a pathophysiological manifestation, so that there's kind of a broad range of outcomes. And then there were some other steps beyond this that I won't talk about today that included selecting outcome measurement instruments for each of the outcomes. So reviewing, for example, existing tools and questionnaires, coming up with standardized definitions, and so on. And so our final core outcome sets, along with all of these methods and including the outcome measurement instrument selection, were just recently published, and the citation is there if people are interested. So to conclude, developing core outcome sets using consensus methods with multiple stakeholders, including patients and families, for these rare diseases was valuable and feasible. Patients and family members participated in our Delphi surveys, and they prioritized different outcomes relevant to compared to healthcare providers underscoring the importance of including their perspectives, because of course, they're the end beneficiaries of this research to evaluate treatment. So we want to make sure that the research includes the outcomes important to them. The patient and family partners and advisors, I think, were really critical to the success of the project. And so we used strategies including comprehensive training, particularly for the advisors, many of whom were new to research, an atmosphere of mutual learning on the team. So we were learning from our patient partners and advisors, they were learning from us, inclusivity and flexibility about how involved people wanted to be. In terms of next steps, we're currently developing a Canadian PKU registry that will integrate the measurement of the core outcome set, and we're developing core outcomes for some additional inherited metabolic diseases and developing registries as well. And of course, the reason why I'm here is that I think some of these methods could potentially be transferable to other rare diseases. So finally, I'd like to acknowledge our patient partner co-investigators, Maureen Smith and Nicole Pallone, all of the Family Advisory Forum members, our talented group of research staff and trainees who are involved in this project, the co-investigators, and our funding, which is from the Canadian Institutes of Health Research. Thank you.
Thanks so much, Beth. That was wonderful, and I'm so glad that we've had the opportunity to work with you as well on some of the surveys here. I do hope and look forward to a continued relationship over there. Looking forward to the Q&A session where hopefully we'll hear more from our patient members, patient community. At this time, I'd like to go ahead and welcome Mark Levin. Mark, if you're there, and if you could confirm for me that your audio and video access has been enabled.
I think so. Can you hear me?
Yes, I can. Thank you.
Great. Let me just share my screen.
And while you do that, I'll provide a brief background. Dr. Levin is a pediatric cardiologist with expertise in non-invasive clinical cardiac measurements, as well as molecular cardiology. He has studied both CTD mouse models as well as patients from the clinical perspective, specifically with relevance to their cardiac manifestations. And his slide is up, so you know what the title of his talk is, and I'll let Mark take it away from here.
Thanks very much.
If you could just, what I'm seeing now is the presenter view. So if you have a dual monitor, you might have to switch displays to enable a slide view.
Okay.
So you can go to slideshow, and you can, if you do, you can do play from start if you need the presenter view, but if you have dual monitors, you might have to just switch displays. So at the top where you see
swap display?
The switch display, yeah, there you go.
Okay, how's that?
Perfect.
Okay, great. Thanks very much. I want to start by thanking the organizers for inviting me to give this talk. As mentioned, my name is Mark Levin. I'm a pediatric cardiologist at the NIH, and I spend my time doing both basic and clinical research on sudden death mechanisms. And I'm going to talk to you today about some work I've done recently that we just published on creatine transporter deficiency. And the data covers both mouse and human data. So this is the citation for the publication. Everything I'm going to say today is contained in this publication, and I want to take this opportunity to acknowledge my co-authors who are listed here. I also want to thank Laura Baroncelli, who was kind enough to share her animal model, and also thank Loomis and Ultragenics for their support of the research as well. One important thing I want to underline is that this work seems to raise questions that I don't have the answers to, and I just want to make sure that's clear. Specifically, this work raises the question about increased risk, but when we actually went to see the clinical effect on patients, we didn't come up with any data that demonstrated patients were really suffering increased sudden death. So the question is it not occurring, or is it just that data isn't making it into the literature or through to clinicians? So hopefully participation in the registry that's being started will help to clarify that. One thing I can tell you is that if I were to take anyone watching and have a medication that would prolong their QTC to 500 milliseconds, that would put them at increased risk. And as a pediatrician and a parent, our aim is often to minimize risk. So from that perspective, at least, I think this is important. So this background slide has been covered by other people, so I'll very briefly cover it here. As mentioned, creatine acts both as a sink and a source of phosphate bonds to help in the regeneration of ATP. Creatine and creatine transporters enable transfer of energy intermediates throughout the body. This protein is made in the liver and not significantly in the heart, so it needs to be transported into cardiomyocytes for its effect. And that's performed, we think, by SLC6A8, which is a gene encoded on the X chromosome. Males harboring pathologic mutations in this gene have creatine transporter deficiency. It's a multi-system disease with profound nervous system effects. Digestive disorders have been described, and to a lesser extent, cardiac effects have also been described. Again, this protein is expressed in human cardiomyocytes, and you might predict that disruption in this protein's function would result in compromised myocardial function because the heart has very high energy needs and requirements. It's unclear, however, as I mentioned before, whether this is clinically important to patients with CTD. It's unclear if any patients have died from cardiac disease who have CTD, but we did find a finding that I'll detail in a few moments. Again, if you were to extrapolate from another disease, long QT syndrome, having a QT of roughly 500 milliseconds would confer increased risk. So we don't like risk in our children and patients. What you see in front of you are two ECGs from CTD patients. On the left is an ECG with a normal QTC, and on the right is an ECG from a patient with a prolonged QTC. Well, the question arises, what the heck is the QT and why do we care about it? Well, simply stated, the heart is a pump, and that pump is controlled by an electrical system. The QT is a reflection of how that electrical system functions. And the analogy I like to make with parents I speak with is that think of the heart as having an on and off switch, and to reset that switch, you need to turn that switch back off. And that's what I would loosely term the repolarization. It's that repolarization time that's really critical to the process. And in this related disease that I mentioned, long QT syndrome, it's the repolarization period that's abnormal. Moreover, what is seen in this other disease is that the degree of risk is proportional to the length of that QTC. I should also mention that I keep on switching back between QT and QTC. The C stands for correction. There's a rate correction for what is normal for a QT. So specifically, what is normal is dependent upon how fast or slow the heart rate goes. And so there's a mathematical formula that we use to normalize that. So again, here on the left is a diagram that shows how we actually measure the QTC. Again, when we performed these measurements throughout the cohort that we studied at the NIH, we found a very high proportion of patients who did have a prolonged QTC. And we divided the cohort into those under 470 milliseconds and those greater than 470 milliseconds. We chose that because that's the 99th percentile. And again, as I mentioned, when you get close to 500 milliseconds, that's when pediatric cardiologists' ears perk up. When we looked at cardiac structure by echocardiogram, based on the electrocardiographic abnormalities, we saw something, again, very interesting. Specifically, what we saw was that those with prolonged QTCs were more likely to have structural abnormalities. Again, I use an analogy that when we do an ultrasound on the heart, one does a cross-section through the heart, and the heart looks like a donut there. And there are several different measurements that we look at. One of the measurements is the left ventricular internal diastolic dimension, and that's equivalent roughly to the size of the hole of the donut. And what we found is that in patients with the prolonged QT, the hole or the volume of the left ventricle looked dilated. And that is consistent with the process of possibly going on to develop dilated cardiomyopathy. In a similar way, you can look at the wall of the LV or the cake of the donut, and that dimension is called the left ventricular posterior wall dimension in diastole, which is shown in the graph on the top right. And again, consistent with a developing dilated cardiomyopathy phenotype, the wall looked thicker, or the cake of the donut was smaller. I should add that no one had a true dilated cardiomyopathy. Part of the definition of that is that the squeeze is diminished, and we saw no abnormal small squeeze in the patients. As I mentioned, we were able to use a mouse model of engineered to have no transporter protein, and we were able to look at ECGs in these mice to see if there was a similar abnormality in the electrocardiogram, and we in fact did find that. One thing that's obvious here is that it's a little more difficult to measure the QT in a mouse than it is in a human. That's partly because the heart rate's about 10 times faster. And you can see that the end of the T wave is really, it's less clear and more subjective. And because of that, we think it's really important that those people measuring that dimension be blinded to the actual genotype, which was the case. When we looked across cohorts of both normal control mice and those with the engineered abnormal protein, again, we found that the QTC was prolonged in the engineered mutant mice. And we went on to do similar echocardiograph studies on these on their hearts, and again found abnormalities consistent with a possible cardiomyopathy. Again, this LVIDD dimension pertains to the chamber of the heart, or the hole of the donut, and we looked at 3 months and 9 months. At both time periods, we found that the hole looked bigger, or the chamber looked dilated compared to the control. Unlike in the human, where we saw the chamber was thinner, we found that in the mice, the chamber was thicker. Again, it's not completely inconsistent. Some people in the field argue that before an animal or patient goes through a dilated phenotype, they first have a hypertrophic phenotype. Again, as in the case of the human patients, function was preserved, or there was a normal squeeze in the heart, as evidenced by this fractional shortening. Well, most striking from this study was that when we looked at the mouse survival over the period of about 400 days, we found that the control mice died spontaneously at a rate of about 1% over about 400 days. But by contrast, those mice engineered with the mutation died spontaneously at 42% of the time. So again, this is consistent with our concern about a risk of sudden death, but it remains to be seen what might occur. So in summary, patients with CTD have prolonged QTCs and echocardiographic abnormalities consistent with developing dilated cardiomyopathy. Mice modeling CTD have similar QTC prolongation and echocardiographic changes consistent with developing cardiomyopathy. We can use the mouse model to study electrical changes in the hearts of the mice, and this will probably give us some insight into possible abnormalities demonstrated by CTD patients' hearts. From a clinical standpoint, it's very important, I think, for patients with CTD to have a local cardiologist to investigate things further. And hopefully I'll have time to go into some details of that in the question and answer, but I'm happy to work with local cardiologists, and you can see my contact information there. Thanks. I also want to stop and the recommendations I have passed along to the society, and hopefully those will be on a website. And I want to thank all of my co-authors. Thank you for your attention.
Thanks so much, Mark. I think your talk definitely raises questions on what we can see in the patient community. I know you've asked about whether there are instances of sudden death. Certainly don't intend to speak for the community over here, but I don't think we've observed that firsthand. If somebody has instances otherwise, I think it would be a great thing to bring up in the Q&A session. At this time, I'd like to invite our moderators, Dr. Sarah Young and Carole. If you have your audio and video enabled, please go ahead and turn those on. Just a quick introduction about our moderator panel. Our panel consists of an expert, so academic expert, Dr. Sarah Young, as also a parent community member. So Carole is a parent of a child with CTD. The purpose of having a moderator panel like this is to be able to represent the patient voice and put our community in the center about so many of these questions that pertain to them. So with that, I'll hand over the baton to Carole and Sarah. You should find questions in the Q&A box. And so please go ahead and direct those to the speakers.
If I may start, Sarah, unless you want to start.
Please go ahead, and thank you.
Okay, so good evening all. Thanks to Aurora, Beth, and Mark for very interesting presentations. So I'm going to start with the question for Aurora. There's a few questions about your presentation, and one of it is there any difference in the types of cognitive defects based on the gene deficiency? For example, is autism or ID in CTD differ from the other X-linked ID disorder? The second one is about the age of the children. You mentioned that those were performed by 4+ children. In your experience with other rare disease in the past, is there any metrics that could be designed for children under 2, i.e. very young children? And the last thing is, I think is an interesting point, because there's often critique of measuring cognitive outcomes in clinical trials as they don't change enough over 6 months to capture drug benefits. So what are your thoughts on that? How to integrate these in a meaningful way in trials? And is there secondary measures?
Okay, all in one. Okay, so the first question was about specificity about autism. So that's a very good question, and that's why we decided to include a specific assessment for autistic kids in the next observational study that we would like to perform in France. So I do not have yet the answer for CTD patients, but I can, for example, give you an example about what we know now very well about Fragile X patients, another X-linked condition. So basically, Fragile X patients, some of them are having autism, real autism, autistic spectrum disorder, with all the criteria and everything, but most of them are having like what is called autistic features, but they are not really autism. Like if you really have an autistic spectrum disorder, basically you are not interested in interacting with people. What is interesting you are things that will not be understandable by people who are, as they called, neurotypical, which is not a compliment from someone who is ASD. Of course, and that's very interesting to understand their point of view too, because I think that they can feel and things that we do not see. And that's interesting to see it both ways. So in Fragile X patients, for example, we know for sure that most of them are improving within the dual interaction. Basically, you are engaging them and they are really improving, which is not typically the case with someone who has autism with no Fragile X patient. So, for example, there are things that we can know and see from one specific gene. So I expect that it's likely that there can be some specificity related to CTD genes, but up to now, to my knowledge at least, it has not been described by anyone. The first descriptions were based on questionnaires and were not really very well more than that described. So I don't think that I can answer more than that for this. Regarding the next one, it was about the age.
The age, yeah. Do you have like a measurement for younger kids?
Yeah. So basically, it was the point of our new outcome measure tablets, especially and eye tracking. So basically, the first matrix task, I mean the matrices I showed you, was performed above 4, but all the other tasks were performed with children above 3. So it's something, and I think that we can even go lower, with, for example, the eye tracking tasks. But that's true that it's not easy to assess the cognition of a child with intellectual disability who is really young, because you have to be sure to engage them. But I think that what we called developmental scale, such as in France we have the Brunellesine, but I think that in the US you have the Bayley Force, for example, the Bayley scale, which is basically assessing a child, mainly observing the child and seeing how he can develop. So basically, during the first 2 years of life, as you know, the 4 domains, language, social interaction, motor, fine motor skills, and gross motor skills, are very important milestones that you can monitor. And it gives you a lot of information about the development of the child. For example, to know when he can hold his head, when he can sit down without help, when he can walk, all these steps, and the language development. It gives you a lot of information about the children. So yeah, I think that developmental scales are interesting. I know that the Mullen is also very used in the US. So yeah, you have different scales, but the problem of this. Yeah, the problem.
Thank you, Dr. Curry. Thank you very much.
Yes.
We have quite a lot of questions in the chat, so I'd like to move along and just request that the speakers just, if you can give short answers to make sure everyone gets. Thank you so much. That's very, very interesting. I know there was a third question, but before we do that, can we just rotate to Dr. Posse? There was a question about the core outcomes and whether there have been any instances of family involvement that has resulted in the identification of outcomes that were not previously identified.
Thanks for that question. And yes, this kind of area of core outcomes at development, a lot of the work arose in the originally in the arthritis field, and actually with the observation that when patients and family members were involved in selecting outcomes for research, some of the sort of daily concerns, and notably fatigue, became much more highly prioritized compared to when it was only healthcare providers. And in one of our workshops, in discussing some of this, some of our patients and families talked about interactions with specialist providers and wanting to focus in those limited interactions on potentially more disease modifying therapies and really important kind of medical management fundamental to the condition. And so sometimes not necessarily wanting to spend time in their appointments talking about some of their daily life struggles. And so and that could be a potential reason why sometimes the healthcare providers weren't aware of just how important some of these kinds of outcomes around things like sleep, behavior issues, sometimes pain, things like that, tend to kind of rise up in the priority list when patients and family members themselves are involved in selecting outcomes.
Thank you. I would like to, Carole, is it okay if we rotate to a Dr. Levin question, and then we can maybe do round robin? So great work, Dr. Levin. Do creatine transporter deficient patients show heart dilation, as in creatine transporter null mice? Could humans have another creatine transporter in their heart, whereas mice only use the creatine transporter one in brain and heart and skeletal muscles?
Yeah, those are excellent questions. Let's see, the first question is there heart dilation? Yeah, it looks like there is some heart dilation in the mice, and it looks like there is some subtle heart dilation in the patients themselves. As far as maybe an alternate transporter, that's obviously something we thought about it as well. And it's an excellent question. So far, as best I can tell, so far there's not been any evidence that such a transporter exists, but it certainly, there's a big incongruity between, the amount of metabolic requirements that the heart has and what would occur if such a transporter doesn't exist. It's hard to imagine that the heart would function at all. So it does suggest that there's some other mechanism there, but as far as I know, and as far as people have been able to determine, no one's identified that. Was there a third part of that question?
I think you answered it basically. It's just whether or not there was a difference between mice and humans and the type of transporters in the various tissues. So
yeah, again, I don't think there is, not that I've been able to find, but it certainly is a reasonable partial explanation for what might be seen.
This question is for Dr. Curry and Dr. Potter. Have the outcomes each of you have discussed been used in clinical trials?
So not yet for the one I showed, but I certainly hope so.
Yes, in terms of some of the outcomes that we've discussed, a lot of the sort of candidate outcomes that we started with were outcomes that have previously been used in clinical trials. And so I think some of this is more a matter of what's emphasized in clinical trials as opposed to things that have never been tested in clinical trials.
Carole, do you want to lead the next?
Yeah, yes, there's another question, Dr. Levin, from a mother. Would you recommend an EKG to be performed on CTD children, like on a regular basis, once a year or twice a year, or one-time EKG is sufficient?
Again, the short answer is I'm not sure exactly what's going on. And there's, even as you can listen to today, there are discrepancies between what different researchers find and see. So while you're, when I'm uncertain, I like to try and get information. So my recommendation, and again, I'll try and forward them so the recommendations can be circulated more widely. I would get a yearly EKG. I think that, there are certain times where kids' EKGs seem to change more than others, but broadly, the safe answer would be I'd probably do it yearly, but that might change as we get more information.
Okay, thank you.
Sure.
Okay, there's another question for Dr. Curry. Can you talk from your experience with other rare diseases that present with intellectual disability? Are there any metrics that can be designed for really young children? Have you already had that question? I apologize. I copied that twice. There was a third question. I think it was the examples of clinical trials where these outcome measures change with intervention, i.e. can they be quantitative?
Yes, of course. It's why developing these outcome measures are so interesting. It's so interesting because I think that, as I mentioned, a lot of ID patients are failing the test. So basically, you have a floor effect. And to get them to improve a little bit on a test, a classical neuropsychological test, it's very difficult because those tests were designed not to assess ID patients. They were designed to differentiate between ID patients and typically developed kids. So it's not done to study ID patients. That's why we developed these tools, because I think that these tools are going to be much more sensitive. And as you can see, we developed a very, very simple condition in order for them, to have range of improvement. I think it's really important to understand that. And also, when you are using parametric actual measurements like eye tracking, like reaction time, like error rate, I think that these kind of measurements are more sensitive to change than a usual scale. For example, it would be something great, of course, if like after treatment you can change and perform a Wechsler scale, whereas we could not before. Of course it would be great, or if you can gain, I don't know, 10 points on the IQ level, of course it would be really great. But to achieve this would mean that you have a huge change, which is of course interesting, but before that I think that you need to have some intermediate steps and to measure a smaller effect.
So I know we are out of time. Our Q&A session has ended. However, there are two questions that I have that I'd like to pose before I can release people for a break. So if you'll bear with me, Mark, one question. I know we spoke about cardiac abnormalities in your talk, and as I said, we're not seeing instances of death. If those exist, we're not hearing reports from the community. But are there any other behaviors that parents can look out in their children, these types of abnormalities? What would they manifest as? And I'm going to give you a couple examples to give you where my head is at. Would it be that children may not be able to tolerate exercises that are cardiac strenuous? Would these lead to loss of consciousness that could be mistaken for a type of seizure? What would we be looking for in terms of patient manifestations?
Yeah, so those are great questions, and again, there are common and uncommon causes of all these symptoms. So even if you see these symptoms, parents are not. Even if your parent is a physician, it's not, your parents are not responsible for being the physician. They just need to raise these questions, and they should raise these questions with a physician and probably a pediatric cardiologist. As sort of a background to this question, which is a very important question, for a long time when long QT was first described, which is intrinsically a cardiac problem, it was misdiagnosed by a lot of people as seizure disorder. So it's very tricky because even for those trained in these areas, there's a clear overlap in basically if you don't get oxygen to your brain because your heart's not working, you will seize. So there's a real overlap, and there's obvious confusion in the phenotypes. The triggers that I like to mention to parents are passing out or coming close to passing out. Those are really sort of the hallmark things. And with respect to details of that, if it occurs, again, it could be a seizure. There are ways of trying to discriminate whether or not it's a seizure or not from a physician standpoint. And that basically involves monitoring in different phases based on the level suspicion. You wear a Holter monitor, which is like an ECG for 24 hours. They have patches that kids can wear for 2 to 3 weeks. And if you get very concerned, you even implant under the skin a monitor that kids will wear for a year. That's the big red flag that I would raise. The other red flag is has to do with what you mentioned, exercise tolerance. So, if kids are developing true dilated cardiomyopathy, the symptoms that I would expect to see are, my child was able to do X amount of exercise. We weren't sure if he was doing less exercise, but over the course of a month or so, we are convinced he's definitely doing less exercise. That's the sort of time frame and quality of the symptoms I would expect. But again, I think it's low likelihood. We evaluated, I think, close to 30 kids in the NIH natural history study. None of those kids had true dilated cardiomyopathy. It's still good to know the symptoms, but those are them. The more concerning thing is this idea of there are different forms of long QT syndrome, or what's called acquired long QT syndrome. That's what I'm more worried about. So specifically, maybe there's a mild prolongation because of the underlying disease in CTD, and then a child takes a medication that prolongs it even more. That is what I'm worried about, and what I'd like to try and educate about, to make sure that kids are not taking medicines that are prolonging the QT, and if they are, to work with physicians about trying to peel those medications off and exchange them for ones that don't prolong the QT. You have a question? Sorry, Aurora?
No, it's just that I think it's very interesting what you described, and especially because of the new, the future clinical trials. I think it's very important to be careful about that and to check that in the, in the preclinical testing in animal models, especially. I think that they have to be very careful about this aspect, I think.
Yeah. So again, as I mentioned in the beginning, anyone's QT, if you take anyone and their QT is as prolonged as what we found in these kids, they're at risk. Even if so far we've been lucky, knock wood, no one's had issues. It's the kind of thing that you don't want risk for your child if you don't need it. And so we'd rather do preemptive work than have to deal with something bad.
Awesome. Thank you so much, Mark, for shedding light on that. I think we may have to follow up with a Reddit-style AMA at some point to get all of those queries answered. But thank